Uh, Hello, everybody. I would like to welcome you all in today's activity of the IAVA. Today is the IAVA cardiorisk wave. This is the 8th wave, and in this occasion, me and the board decided to present to you a program involving the role of liver in hepatic in lipid metabolism and the effect of lipid-lowering drug on the liver. So, celebrating the World Hepatitis Day today with me, Professor Ahmed Shawqi Sarafi and Shams University, Professor Mohammed Salim, National Heart Institute, Professor Said Farag, Zagazig University. There is some changes in the program. We will start with Dr. Ahmed Shawqi, the role of liver in lipid metabolism. And I'm eager and waiting to see. I'm sure Dr. Shawqi had a tough time to prepare this lecture for you, to be followed by Dr. Mohammed Salim discussing with you a very important topics about the effect of lipid-lowering therapy on the liver, when to stop, when to do investigations, what is the complications, if there is there any. And lastly, not least, Professor Said Farag will present to you how to optimize lipid-lowering therapy for cardiovascular protection. So let me now take 30-second break and stay with us to start the program. So welcome again, and before I introduce the first presentations, I would like to thank Abbott Company for their non-restricted educational support and sponsoring of this CME activity of IAVA in the occasion of the World Hepatitis Day. And of course, I would like to, as usual, thank ICOM Company for their technical support and their magnificent platform. So let me introduce for you Professor Shawqi and liver and lipid metabolism. Dr. Ahmed, Faddal.
Thank you so much, my dear Professor Ashraf, Professor Said, Professor Mohammed. It's always a pleasure and an honor being with the IAVA board in these educational forums. Actually, yes, I did have a very nice time. I went through a lot of formula, a lot of data, and actually the liver and its metabolism in the lipids, glucose and protein is extensive. And we know the liver is the second largest organ in the body. And of course, it does have a lot of functions, including vascular, immunological, metabolic, and secretory. It takes around 30% of the cardiac output. Most of it is coming from the portal circulation and partly from the hepatic artery. Around 50% comes for the oxygen comes from the portal circulation and 50% from the hepatic artery. But the portal circulation is extremely important because this allows the first pass metabolism, and thus the liver is a very important part for digestion, for first drug metabolism, for a lot of functions. So this is an important way. And today we're going to take a look really on the lipid metabolism and its effects. We know as we ingest fats, this goes through the stomach, through the intestine, and the bile salts in the small intestine start to emulsify. Action of the lipases in the intestine degrade these, and they start to be integrated into the cells, into the portal circulation, and this circulates both to the liver and to the different parts of the body. So lipid digestion actually starts from the mouth, actually, and the lipase starting from the cell. Discuss this in detail, but I just want you to take a look at this picture. This is what goes on in the liver. It is extremely complex. There's a lot going on when it comes to glucose, when it comes to lipid metabolism, and there's interaction between the catecholamines, the glucagon, and insulin. And this is why sometimes with problems of the liver, we get a fatty liver. with increased triglycerides, with increased fat deposition. So it is a very complex thing that occurs in several parts of the liver, and it is a mainstay for the mechanism of metabolism in the body. So what happens in the liver hepatocytes? We can summarize it by acquisition of lipids, which is intake of lipids, and then fatty acid synthesis, which is lipogenesis. Yes, the liver can synthesize lipids. The lipid storage, including triglyceride synthesis, and lipid droplets, the LDs are very important in management. Lipid consumption also is including fatty acid degradation and the secretion of the very low density lipoproteins, and also the HDL, which comes out from the liver as empty to take up the cholesterol from the body, and this is important. So where do the hepatocytes take up the fatty acids from? From the hydrolysis of the esterified fatty acids in triglyceride, which are driven from the gut, chylomicrons. Also, the hepatocytes have this ability for lipogenesis from excess glucose. Of course, this does not occur in the fasting state. This occurs in the usual state. So what are the fatty acids taken from the peripheral tissue or the endogenous synthesized fatty acids used for? Why is this fatty acids important? First of all, they are energy and ketone body production via the mitochondrial beta oxidation. They can be esterified into triglycerides and stored in lipid droplets. Triglyceride synthesis and VLDL formation with apolipoproteins, and the VLDL is the main export of the liver to the body, and this is important for lipid circulation inside the body, and how it affects our lipids, and LDL also is important. And this is just a simple diagram showing what goes for the free fatty acids in the hepatocyte. And this is important because every single enzymatic conversion that occurs, there is an idea of medication to try to stop this and thus reduce the lipid metabolism inside the liver. So let's start at the very beginning. The liver uptakes the lipids mostly through passive diffusion, and sometimes a little bit through what we call more transport for the long chains by the translocases and the transporter. The plasma fatty acid level is one of the most important parameters that cause the rate of fatty acid uptake from the hepatocytes, and also if the liver can take what we call the hepatocellular capacity, this really helps. So it's partly from passive diffusion and also transporters like the fatty acid transporter protein. Lipogenesis, on the other hand, occurs in the cytosol. The synthesized lipid droplets and triglycerides are secreted as VLDL, and this VLDL is very important to spread the lipids inside the body and to exchange and to go to the cells that really require them, whether to store them as fat or to use them as energy, and then through an enzymatic process they can be turned into IDLs and LDLs, and this is really important. An important point about lipogenesis is that insulin stimulates lipogenesis through the sterol regulatory element binding protein 1C, and this can cause in obesity an increase of deposition in fats around the body and fatty liver, and this is another important thing in insulin resistance. Then beta oxidation occurs through the mitochondria and peroxisomes. This occurs accordingly: the short chain fatty acids in the mitochondria, the medium and long in the peroxisomes. And PAPAR alpha is a pivotal positive regulator of this oxidation. PAPAR gamma has a different job. Then triglycerides are synthesized mainly in the liver, but also they can be synthesized in the adipose tissue and small intestine. Don't forget that. It's not only the liver, it's also the adipose tissue and the small intestine. And the synthesized triglycerides of the liver are stored either in lipid droplets or VLDL particles. And this is also managed by several enzymatic mechanisms, and they play a pivotal role. So far, we don't have any medication to affect these diacylglycerol acyltransferase drug, but it is another option for management of these patients. Then the VLDL, the main export of the liver, is done through a complex process when there is ApoB and the microsomal triglyceride transfer protein, or the MTP. These two actually increase the VLDL assembly. They increase also the LDL. And these have inhibitors right now that are used as familial hypercholesterolemia medications. So it's the ApoB, which can associate with the neutral lipids and provides the framework for the assembly of the VLDL, and the MTP, which helps the translocation of full-length ApoB100 and its components, facilitating ApoB secretion. These two things, ApoB and the MTP, these are two different ways of managing familial hypercholesterolemia. Then the VLDL is secreted to the adipose and other peripheral tissues, and it is hydrolyzed and giving lipids for the cells, for storage, for energy, and they are then converted into IDLs and then converted to LDL. So this is an important pathway too that shows that the VLDL provides an important part of the circulating adipose or lipids in the body. The lipid droplets is a different idea. These are present in virtually all types of cell and are consistent of a triglyceride core and a phospholipid monocells containing structural proteins. Papar gamma helps the promotion of LD accumulation and lipid storage. And this is why if papar gamma antagonists, these are also what we call targets of therapy to reduce triglycerides, to reduce fatty livers, and to reduce the lipid storage. And this is important when we have excess. So this is the main steps of fatty acid oxidation and synthesis. A lot of chemical and enzymatic processes. We just try to look overall on what's going on. Not only that, but not only the hormones, not only the liver, not only the gut, but there are also genes that have to upregulate or downregulate to provide different energy and different what we call levels of lipids in the bloodstream. Yes, we can have even people who are more prone to an increase in triglycerides, increase in lipogenesis, increase in glycolysis. So again, sometimes some families are more prone to others. This lipolysis preferentially hydrolyzes triglycerides, and it's hormone sensitive with so many hormones affecting it, mainly the catecholamines and insulin and even glucagon. But of course, insulin is the most common. And this tries to sum it up. We take the dietary fats in the intestine, they are transported to the liver, and we see in the liver so many enzymatic processes. The liver's main export is the VLDL and the HDL. The liver can be attacked on so many fronts. You can reduce the production of lipoproteins by the ApoB and the MTP, and we'll show to that. The VLDL goes to the circulation, giving fats to the tissues, giving storage and energy, and this is turned into an IDL. The IDL, through an enzymatic process, goes to the can be transformed to LDL, and LDL does have a function. Not so much as we thought it was, but it also gives cholesterol to different parts of the body that help in cell membrane and stuff. This is the inclusion of the cholesterol metabolism of the liver, including so many signaling pathways, the synthesis of cholesterol lipoproteins. Bile helps absorption of cholesterol, the VLDL, and also the cholesterol secretion into the bile is one of them. But one thing that we should know that there is a diurnal or a circadian rhythm and even a seasonal control of the liver metabolic functions. There are data to support that there is better function of the liver at certain times of the day, but there are conflicting data which part of the day actually. Is it just after a big meal or is it at night? I cannot really have data to support this. We'll need a hepatologist to help us. So let's take a quick look what happens when the liver is diseased, like when they have insulin resistance. There's an imbalance between lipid uptake and lipogenesis. This increases lipolysis, plasma free fatty acids, and delivery of adipose-derived free fatty acids or fatty acids to the liver. And this causes hepatic fat accumulation, what we see a lot in abdominal ultrasounds, which is called the fatty liver. Is it a disease? Yes, it could be, and it's related to obesity, and it's related to insulin resistance. And PPAR gamma has been found to be overexpressed in these individuals. So here, controlling maybe exercise, obesity, and even PPAR gamma modulators may help improve these certain patients. But the most two important things in our body are the LDL and the HDL. The LDL, we know, has so many interrelationships. It has different categories, and it affects the blood particles very badly. It induces atherosclerosis, inflammation, and it increases mortality and morbidity, and its reduction is still the mainstay in patients with atherosclerotic cardiovascular disease. And the liver has an integral role in LDL clearing from the bloodstream through its LDL receptor on the hepatocyte, which takes the LDL particle and goes into a clathrin-coated vesicle, and then this LDL is degraded in the lysosome, and the LDL receptor circles back maybe 200 or 500 times to try to lower the LDL in the circulating body. The HDL, on the other hand, is produced from the small intestine and the liver. It goes to the bodies trying to clear out the bad cholesterol. Thus, this is what we call the good cholesterol. And it also gives cholesterol delivery for the organs that need steroids, like the male genitalia and the female genitalia. And then it is released from the bloodstream either through the kidneys or the liver or the gut. In health, it works very well, reducing the bad cholesterol, trying through the CETP, improving the cholesterol into the HDL and out of the LDL. But in disease, because of the inflammation, the HDL becomes dysfunctional, and thus this is problematic. How to improve this HDL? There are medications that have shown that they can increase the HDL, but their benefit is not that much. But exercise and diet have shown a benefit on HDL too. So if we take a look about medications to improve our patients, first we'll talk about the LDL. We can have drugs that increase LDL removal, like HMG-CoA reductase, statins, those that act in the gut, like the ezetimibe bile acid sequestrants, those that improve the LDL receptors and their function, the PCSK9 inhibitors, and bempedoic acid, which also helps the LDL removal. Those that decrease LDL production, and I remind you, the ApoB antisense oligonucleotides and the MTP, those that are important for the production of VLDL, and those that inhibit the cholesterol exchange between LDL and HDL, which are the CETP inhibitors. And this sums it all up. We have medications that work on the intestine, like ezetimibe, bile acid sequestrants. We have medications from the liver, like bempedoic acid and HMG-CoA reductase, like the statins. We have the important fibrates, which are PPAR gamma modulators and very important in insulin resistance and fatty liver. We have medications, mipomersen, which acts on apolipoprotein B, and lometamide, which works on the MTP, and these reduce the production of LDL and VLDL precursor. We have medications that act on the LDL receptor, like the PCSK9 inhibitors and the RNA, which is also the inclisiran. And we have medications now working on the peripheral circulation, which is not so effective till now. I know it was a hell of a ride, a lot of terms, a lot of enzymatic processes, but the liver is an important, and we should understand it is a major player in the metabolism of lipid. It has several complex procedures which interplay between the liver, the intestine, the adipose tissue, and the peripheral cells. And there are lots of hormones, the catecholamines, the glucagon, but don't forget insulin. And that's why a lot of the time with the obese patients, we see a lot of fatty liver. But understanding the physiology will get us to understand how to manage these processes. And I think the slide before this one tried to sum it up. How we understand the physiology helps us to advent drugs that might help our patients. And thank you.
Thank you, Ahmed. It's really tough subjects. We are essentially clinicians. We know that those with high cholesterol and high LDL cholesterol should take treatment to prevent cardiovascular disease. But it seems that we have to understand much more about these complex metabolic pathways. So the liver produces lipids, mainly in the form of triglyceride from the fatty acids, packaged with some cholesterol to release in the blood in the form of very low density lipoprotein. And this continues the cycle: very low density protein, intermediate density, LDL, and so on and so on. And then at the same time, the liver clears cholesterol or from the body by the LDL receptors, which take the LDL from the blood to internalize in the liver. It seems that there is balance between that. Could our diet affect this balance? For example, when should the liver produce more liver than we need, for example, and what can we do to improve this metabolism in favor of a better metabolic profile in our body?
A very good question, and thank you for summing it up very nicely, Professor Ashraf, as usual. What we thought, and we were discussing this with your kind self before, that there was avoid fatty foods, and fatty foods increase the LDL, fatty foods increase a lot of bad things. Fatty foods do increase a little bit, of course, the LDL, the VLDL, maybe a little more the triglycerides. But the most important part, and this was out of the subject of today's discussion, was the glucose metabolism that occurs in the liver. Carbohydrates are the main precursor for triglycerides in our diet, at least as in Egypt and in other countries. And thus, reducing the carbohydrate intake is a very essential part for reducing this increase in LDL, in triglycerides, in other markers, and of course, also blood sugar. But again, talking about what fats, trans fats are really bad, yes, they help increase, but the main pusher for an increase in lipid profile, which is very atherogenic and problematic for the patients, mainly is the blood sugar or the intake of carbs.
So you wanted to tell us that if I eat a lot of bread and sugar, the liver will produce more triglyceride, more very low density lipoprotein, and my LDL cholesterol will be elevated. This is something,
yes.
It's not new, but something unusual even for the public. They know that when we eat fat, the fat in the blood increased. But now you tell us that when we eat sugar and when we eat bread, a lot of bread, more than the need of our body, it will elevate the triglycerides and the lipids in our blood. Any comment, Dr. Salim, you wanted to add? Unmute the mic.
Sorry. Thank you, Dr. Ahmed. Very interesting lecture. What I want to ask about is what's called the fatty liver. Okay, this fatty liver is the exaggeration of the normal work of the liver to produce more fat and triglycerides, or it is some sort of dysregulation between different feedback mechanisms in this pathway?
Oh, definitely. It's part an insulin resistance and a dysregulation of some normal processes, but an exaggeration of others. There's an increase. Of course, the normal liver does produce an amount of triglycerides, which is controlled through some enzymes and hormones and a circadian rhythm. But if there is some insulin resistance, there is an increase in also in, especially in glucose in the body or intake also. This dysregulation occurs, and there is fat deposition in the adipose tissue and around the liver, and this might show us what we call the non-alcoholic fatty liver, like you kindly said.
Is a statin or lipid-lowering therapy has any role in fatty liver? I don't know any information about this.
I'm not a hepatologist. Please. Okay, perfect.
In my lecture, Dr. Ashraf, I will touch this point.
Okay, excellent. Excellent. So I think we can now take a 30-second break, preparing for the next presentation, which I'm sure it will be as interested as the first one by Professor Salim. So 30-second break, stay with us and be. So welcome again back to the next presentations, which still in the, we are in the World Hepatitis Day. So what about lipid-lowering drug and the liver toxicity or hepatotoxicity? Professor Salim, Fadal.
Thank you, Dr. Ashraf. It's almost my pleasure and honor to be part of these interesting waves of IAVA. And today we are in the 8th wave, and it is in the day, Hepatitis Day. I'll give you a short story about this Hepatitis Day, which is the birth date of one of the pioneer scientists in the field of hepatitis, Dr. Baruch Blumberg. He's an American physician born in 1925. In this day, 28th of July, he awarded the Nobel Prize for discovery of the viral B hepatitis. And also, he is the one responsible for discovery of the core antigen, hepatitis B surface antigen. At that time, it is called Australian antigen. And also, he is the innovator of the vaccine. So the world and the health authorities and the Society of American Hepatology celebrates this day as Hepatitis Day in memorandum of this great scientist. My talk today is the lipid-lowering drugs and the liver or the hepatotoxic effects. Of course, I have to start by statins. What's the effect of statins on the liver? The activity of alanine aminotransferase, ALT, or previously known as SGPT, in plasma is commonly used to assess the hepatocellular damage. Mild elevation of ALT in patients taking statins occurs in almost 0.5 to 2% of patients, and more commonly it occurs with potent statins or with high-dose statins. The common definition of clinically relevant ALT elevation has been an increase of 3 times the upper level of normal on 2 consecutive occasions and in the absence of any other explained pathology. Mild elevation of ALT has not been shown to be associated with true hepatotoxicity or changes in the liver function, and progression to liver failure is exceedingly rare, extremely rare. Therefore, routine monitoring of the ALT during statin treatment is no longer recommended in the most recent updated guidelines. Statin treatment has been associated with a broad spectrum of hepatic adverse effect, as I will show you in the next slides, but the most common of which is an asymptomatic, mild, and usually transient elevation of serum aminotransferase levels that often occurs in the first 3 months or 12 weeks of therapy. So after 3 months of starting statin, if the ALT is not increased, it will, in most of the cases, it will not increase again. Most of the time, this biochemical finding is not correlated with histopathological changes and therefore doesn't meet the criteria as a true indicator of liver injury. For a liver injury to occur, the biochemical dysregulation or biochemical increase in the liver functions should be associated with some structural abnormalities and histopathological changes in the hepatocytes. And here, in our cases, this doesn't occur in most of the cases. Although the underlying mechanism remains unclear for statin-induced liver changes or increase in the aminotransferase, it may result from changes in the lipid component of the hepatocyte membrane. Inhibition of HMG-CoA reductase will lead to some changes in the component of this lipid bilayer and increase in its permeability with subsequent leakage of liver enzymes. So it is simply, in most of the cases, it is just leaking due to increased permeability rather than due to actual hepatic or hepatocyte damage. Clinically important statin-related hepatotoxicity is an extremely rare, as I have just mentioned. Thus, when suspected, the first step should be to rule out other causes. Patients treated with statins who present with persistent elevation of ALT more than 10 times the upper limit of normal often have associated comorbid conditions or concomitant use of other medications that known to interact with the statin and increase or induce hepatotoxicity. Medication history, blood tests, and liver imaging to exclude other causes of liver disease are essential to help to establish the diagnosis. And because most of statins are metabolized via cytochrome system, toxicity induced by interacting drugs often contributes to hepatotoxicity. And here is a list of some of the drugs that is well known to interact with the statins and can increase the effect on the liver. We have anti-infective agents like antifungal, for example, ketoconazole. We have macrolides like erythromycin and clarithromycin. We have HIV protease inhibitors used in the treatment of AIDS. We have also important and commonly prescribed drugs, calcium antagonists, verapamil, diltiazem, amlodipine. They are well known not only to increase the muscle-associated symptoms with statin, but also increase the release or elevation of the aminotransferases. And other miscellaneous drugs like cyclosporin, danazole, amiodarone, anti-ischemic treatment like ranolazine, grapefruit juice, nifazodone, and gemfibrozil. This study examining the incidence of elevation of ALT level more than 3 times the upper level of normal among different trials, we see that in this slide with incremental dosage of statins, in most of the trials there is no significant elevation of the ALT above 3 times the upper level of normal, maybe only in this proved trial in the arm of pravastatin with 40 milligram in comparison to atorvastatin 80 milligram, there is a significant increase in the liver enzymes above 3 times the upper level of normal. But in other important trials like HBS, like Excel, Jupiter, AF caps, all of these, there is no significant difference between the two arms of the study regarding exceeding the level of ALT above 3 times the upper level of normal. If we will come to important question, is there any statin that has been shown to increase the liver enzymes more than the others? In this meta-analysis, we showed that Atorva, Flova, Lova, Prava, Rosova, Semva, all of the statin, we can see that fortunately the most potent statin like atorvastatin and the rosuvastatin are associated with the least elevation of ALT or AST above the 3 times of upper level of normal. And we can see with the old generation of statin like lovastatin and the pravastatin, the incidence is more, but the highest incidence was with simvastatin 80 milligrams. So simvastatin 80 milligrams was not used anymore because of significant increase of liver enzymes. Here is the summary of the types of liver injury associated with statin use. As we see here, the asymptomatic elevation in aminotransferase, which occurs in 0.1 to 3%, it is dose-dependent, class effect, clinically not significant in most of the cases. We have a very rare occurrence of clinically significant acute liver injury, may be seen in combination with other medication, even with some of other hypolipidemic drugs like ezetimibe, but it is very rare. We have also the third type of liver injury is called fulminant hepatic failure. It is extremely rare, only isolated case reports in the literature. It was estimated that the risk of fulminant liver failure with statin is only 2 in 1 million. And we have another type of injury, which is called autoimmune hepatitis. Also, it is very rare case reports, and statins may induce this reaction of autoimmune hepatitis only in genetically susceptible individuals, so it can be considered as idiosyncratic reaction. How we can approach for a patient with elevated liver enzymes? As in any case of elevating liver enzymes, the Society of the Liver Disease, the American Society of the Liver Disease, recommending to asking 3 different questions: how this pattern of elevation, magnitude of elevation, nature of alteration, for example, mild fluctuation, steep progressive increase, rate of alteration. So if we have a rapid spike and then decrease, it is different from mild, moderate, severe increase, but in a steady or steep increase. And if this increase is steady and progressive, it usually indicates hepatocellular predominant injury, but when it is fluctuating, it is usually of cholestatic nature or due to intrabiliary cholestasis. And where, for example, patient ethnicity, some ethnic group showed some exaggerated response by elevation of the liver enzymes with statin more than other ethnic groups, local epidemiology, and patient history of recent travel, which can explain exposure to infection like cytomegalovirus and other viruses, that will explain the rise of the enzymes, but it comes as a coincidence with taking of the statin. When this elevation, timing of the enzyme alteration in relation to the patient age, ingestion of medications that will increase further the liver enzymes, and other comorbid conditions that will affect the liver functions. As you see here, this is the spectrum of elevated liver enzymes generally in the liver disease. It was shown that the highest level of elevated liver enzymes occurs with ischemic or toxic liver injury, followed by acute viral hepatitis, autoimmune hepatitis, alcoholic liver disease, and in liver cirrhosis and the chronic hepatitis, it looks like the level of elevation of the liver enzymes here is similar to that occur with statin. It is mild and it is also transient. This is a wide range of presentation from normal to moderately elevated enzyme. We have numerous other causes of elevated liver enzymes. Most common cause, over-the-counter pain medications, statins, of course, alcohol, heart failure, hepatitis, non-alcoholic fatty liver disease, and obesity, and other causes that will cause actual hepatic injury like alcoholic hepatitis, autoimmune hepatitis, celiac disease, cytomegalo and Epstein-Barr virus, some inborn error of metabolism like hemochromatosis, Wilson disease, toxic hepatitis, thyroid disorder, polymyositis, many other causes that should be excluded if the patient is taking statins and we can see marked elevation exceeding 10 times the normal. This is extremely uncommon with statin, and all these causes should be examined and excluded. These are the most recent recommendation of the American College of Cardiology, American Heart Association about the statin safety recommendations. It was mentioned that moderate intensity statin therapy should be used in place of high intensity statin therapy when patient characteristics predisposed to statin associated adverse effects, and among them the unexplained ALT elevation more than 3 times upper level of normal. Hepatic transaminase levels should be measured before initiating statin therapy and during therapy only if symptoms suggesting hepatotoxicity arise. So no need for routine every 3 or 6 months monitoring of these liver enzymes. And it is the same recommendation also with the most recent European Society of Cardiology guidelines in 2019, in which before treatment we have to assess the liver enzymes ALT, and only we can do it once more after 2 to 3 months or 8 to 12 weeks after starting a drug treatment or after dose increase, and routine control of ALT thereafter is not recommended during statin treatment unless symptoms suggesting liver disease evolve. During treatment with fibrates, control of ALT is still recommended, not with the statins. So with fibrates, it is recommended to regularly monitor ALT, but in statins, after the second assessment, after 2 to 3 months, it is not recommended anymore. What if the liver enzymes become elevated in a person taking lipid-lowering drugs, and if this elevation less than 3 times upper level of normal, continue therapy, don't be panicked, but recheck liver enzymes in 4 to 6 weeks, and if the level is still below 3 times the upper limit of normal, you have to continue the therapy. But if this level exceeding more than 3 times, you can shift or decrease the dose or shift to other statin. What if the liver enzymes after 8 to 12 weeks become more than 3 times the upper level of normal? Stop completely the lipid-lowering therapy or reduce the dose and recheck after 4 to 6 weeks. Cautious reintroduction of therapy may be considered after ALT has returned to normal. If ALT remains elevated, check for other reasons and exclude for other causes of elevation of liver enzymes. Consider low-dose statin, alternate day or even once or twice per week dosing regimen, or combination therapy by low-dose statin and other locally acting drug like ezetimibe. This is the summary of recommendations of the liver expert panel to the National Lipid Association of Statin Safety in 2016. Asymptomatic increases in aminotransferases are a class effect of statins, and they don't indicate actual liver dysfunction or disease. Liver failure causing death or hospitalization or requiring liver transplantation is very rare from statins, and current evidence doesn't support routine monitoring of liver enzyme levels and liver biochemistries in patients receiving statin. Presence of chronic liver disease and the child's A cirrhosis should not be considered a contraindication for statin use, and current evidence even supports the use of statin to treat hyperlipidemia in patients with non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, NASH, and it was shown in many trials that statins are very helpful and very beneficial to decrease this non-alcoholic steatohepatitis. Statins should not be used in patients only with active liver disease, and physicians typically avoid statin in patients with elevated liver enzymes. However, this is a problem because some of these patients, these lipidemic patients, have significant prevalence of underlying non-alcoholic fatty liver disease, and patients with non-alcoholic fatty liver disease would tremendously gain benefit from statins due to their heightened risk of cardiovascular disease. So we are depriving those patients from very beneficial effect of statin, both on cardiovascular outcome and also on the hepatic condition. Patients with chronic liver disease and compensated cirrhosis should not be excluded from receiving statins to treat their dyslipidemia. The Statin Safety Task Force of the National Lipid Association recently recommended that chronic liver disease or compensated cirrhosis should not be considered as a contraindication for statin. If we will come here to other well-known hypolipidemic agent that actually more hepatotoxic than statins, but unfortunately statin almost always blamed by these irrelevant hepatotoxic effect, which is the niacin. Niacin is available in many over-the-counter preparations and packages in many like Walgreens, CVS, Walmart, all these containing this on shelf niacin, and almost any formulation of niacin can cause hepatotoxicity in doses that exceeded 2 to 3 grams per day. But the sustained release formulation is significantly more hepatotoxic than the immediate release formulation, which if used in recommended dosage, it will never cause serious liver injury. But unfortunately, in most of the cases, this niacin was taken and sold in markets without medical supervision or without advice from the physician. The over-the-counter sustained release formulation of the drug is not FDA approved for the treatment of dyslipidemia, but still available to patients for this purpose as a supplement or some sort of neutral medicine. It's called a nutraceutical, and half of the patients that take niacin sustained release formulation develop asymptomatic elevation in transaminases. This is a very high percentage among patients taking niacins, of course, exceeding more than statin medications. What about the fibrate? Several studies have linked clofibrate and gemfibrozil to hepatomegaly, hepatocyte apoptosis, and hepatocarcinogenesis in rodent models. This increased cancer has not been seen or proven in human beings. There is a case report in the Spanish literature of gemfibrozil leading to cholestatic hepatitis and still other rare reports of hepatocellular injury, almost uncommon. Phenofibrate may vary, may be very rarely stimulate or instigate or can induce an autoimmune hepatitis type reaction with the resultant decrease of the biliary ducts, or what's called ductopenia, which will lead to some form of clinical condition like obstructive jaundice, chronic hepatitis, and fibrosis, especially when used in combination with statin medications. Ezetimibe, all of us know that it is safe. However, recent studies have noted that ezetimibe may rarely cause hepatotoxicity in the form of severe cholestatic hepatitis and acute autoimmune hepatitis. Why? Because the mechanism of toxicity here may be related to the metabolism of the drug, and it is rapidly absorbed and conjugated with the glucuronic acid, yielding an active metabolite, and there is significant enterohepatic recirculation. The frequency of increased transaminases was noted to be slightly higher in patients, of course, taking ezetimibe with statins rather than taking statins. My take-home message, finally, although the statins are the most famous or publicized lipid-lowering medications in the arena of drug-induced liver injury, their potential to cause clinically and actual significant liver injury is very, very rare. Sustained release niacin, in fact, is the only lipid-lowering drug that causes clinically significant hepatotoxicity. Ezetimibe has recently been viewed as a safe alternative to or add-on therapy with statins in the setting of pre-existing liver disease. However, recent evidence called this belief into question, as ezetimibe with time showed extensive enterohepatic circulation and can cause intrahepatic cholestasis. There has been a widespread perception that statins are deleterious for patients with underlying chronic liver disease. However, recent several studies and expert opinion currently fully endorse and approving statin use in patients with non-alcoholic fatty liver disease like NASH and other chronic liver disease if clinically indicated. Thank you so much.
Thank you, Professor Selim. Actually, many important messages in your presentation. One of them is that one should not be afraid of giving lipid-lowering drugs if the liver enzyme is elevated, so long it is not 3 times the upper limit of normal. Another important message is that even in patients with documented chronic liver disease, it is not contraindicated to give lipid-lowering therapy up to the level of the presence of cirrhosis, so long the situation is compensated.
Yes.
Before I will ask you and allow Professor Farag and to discuss you in the lipid-lowering drugs and therapy, we have questions for the presentation. I think for the previous presentation from the audience about the ketogenic diet and its effect on the lipid. Actually, the ketogenic diet means that you stop taking glucose, carbohydrates, or taking a minimum amount of glucose and carbohydrates. So the body will utilize the fat for energy production. Utilization of the fat and utilization of the ketone bodies rather than utilization of glucose as a source of energy. This should improve insulin resistance, improve fatty liver, reduce weight. However, the effect of cholesterol is variable. We had with us Dr. Davidson, the expert lipidologist, a few weeks ago, and he explained to us that sometimes, rarely, with ketogenic diet, cholesterol jump, and LDL cholesterol jump to maybe 400 and 500. But this happened, they discovered that this only happened in those with certain specific genetic mutations. In most populations, ketogenic diet leads to some mild elevation of LDL cholesterol that requires risk assessment. The long-term effect of this is unknown. We know that there is some elevation, but as clinicians, I want to say that if you lose 10 to 15 kilograms, if your insulin resistance is improved, if your fatty liver is improved, I'm sure this is very beneficial to the body. Whether the mild elevation of cholesterol LDL has long-term effect is really unknown, and we wait for studies. So back to the your presentation and the effect of lipid lowering. I noted that you told us that niacin can lead to significant hepatotoxicity.
Yes.
This is alone or in combination? If there is any mechanism, because you explained the mechanism of statin, but its effect on the hepatocyte membrane and leakage of the enzymes. Is niacin do the same, or it is a sort of hepatitis, or any mechanism? I don't know.
Yes, the mechanism here with niacin is different from statins. It is not a benign injury. It is actual hepatocyte damage, but only if niacin exceeds 2 grams per day. It is usually sold as a 500 milligram tablets to be taken 2 tablets per day. But for most of the patients, they are taking more than these 2 tablets. Some of them, of course, but this can lead to direct hepatic damage or some form of autoimmune hepatitis. It is unlikely or different from statins. And unfortunately, it can occur with sustained release formulation in up to 50% of the cases.
Okay. So, Dr. Syed,
yes, I thank you, Professor Chauhi. Thank you, Professor Selim, for this elegant, toughly prepared lectures. I know a lot of time you spend in preparing these tough lectures, but at the end of the way, it is very elegant, very clear. I have a comment here and I have a question. The comment is about the effect of several types of fibrates, the gimfoprosil and the fenofibrate. I think from the evidence that the effect of gimfoprosil is much more on liver function than fenofibrate.
Yes.
This is my comment. My question is a practical one. In the previous years, we are in the era of treating hepatitis C. We are still treating, and we successfully, the national project succeed to treat a lot of patients. Most of them, or a large number of them, are also treated for cardiovascular diseases and dyslipidemia. What is the practical approach for managing those patients with antiviral treatment and dyslipidemic treatment also?
Thank you, Professor Syed, for these very important and practical questions. Of the newly introduced antiviral drugs for treatment of hepatitis C, and on top of them is the Sovaldi, there are 2 important drug interactions between Sovaldi and cardiac medications and hypolipidemic drugs. Number 1, with amiodarone and beta blockers. With amiodarone and beta blockers, the heart rate could be substantially decreased and any patient with a baseline heart rate and taking Concor or amiodarone should stop them when he is going to take Sovaldi. This is number one. The second, which is of concern and is related to our lecture today, is drug interactions with rosuvastatin. The only recommended or well-known proven drug-drug interactions with Sovaldi and similar drugs with statins is rosuvastatin. If the patient is taking Atorva or any other statins, you can continue by the same dose as long as the patient is not in the active liver disease or marked elevation of the liver enzymes. But with the rosuvastatin, you have to shift or switch to another statin if the patient is going to take these antiviral medications.
Thank you, Dr. Mohammed. Very practical answer.
So I think, Mohammed, the only contraindication regarding the liver is the presence of active hepatitis.
Yes.
And I think as a cardiologist, I cannot judge whether my patient is active hepatitis or not. Usually, I refer him to a hepatologist, and if the liver enzyme is elevated, and ask my hepatologist whether this patient in active hepatitis or a chronic form of the disease, because I don't know how to differentiate. Do you do the same referring, or you know how to differentiate between active hepatitis and the chronic one?
In most of the cases, if the patient is in active hepatitis, the clinical picture will be dominated by this active hepatitis, usually in the form of jaundice, decompensated liver disease, sometimes fever. And if I'm in doubt, it is, as you have just mentioned, it is more safe to refer the patient for hepatologist for a safe prescription.
Okay, thank you, Professor Salim. And I think we can take a 30-second break. Stay with us, and we'll come back with Professor Said Farad. Thank you. So welcome back again. And again, let me, before the last presentation, to thank Abbott Company for sponsoring this event on the occasion of the World Hepatitis Day. We enjoyed two presentations related to the liver and lipid metabolism, and the second one related to the liver and lipid-lowering drugs. So now we will come to how to optimize the dyslipidemia control to optimum cardiovascular protection. And Professor Said Farad. Professor Said Farad.
Thank you, dear Professor Ashraf. It gives me a great pleasure to be with you, with Professor Salim, with Professor Shawi, in the 8th wave of the CME cardioresc waves. And I hope that the waves give all the audience the fruitful information as regard the dyslipidemia and the cardiovascular in diseases in general. I'd like also to thank Abbott Company for sponsoring our wave today, and also the ICOM company for the fantastic organization as usual for our webinars. As Professor Ashraf said, my title of the lecture today is the optimization of dyslipidemia control. We are in the year 2020. Actually, if I'd like to start, I'd like to start with this slide, which gives us the magnitude of the problem of the cardiovascular disease, which remained the #1 cause of death globally, and above 70 million people died from cardiovascular disease, and that was in 2008. Imagine how the figure now in 2020, representing 30% of all deaths, which is a very big percentage for deaths caused by the cardiovascular disease. Of these deaths, 7.3 million were due to coronary artery disease, which about 6.2 million also were due to stroke. Over 80% of cardiovascular disease, unfortunately, was taken care in low and middle income countries like our country. That's why by presenting this slide, I present you the magnitude of the problem and how we have to have all the weapons, evidence weapons, to counteract this major deadly problem. While statin reduces the cardiovascular risk, as we all know, and as it is well evidenced, but still a substantial residual risk remains. And if you look here to the meta-analysis of 21 randomized clinical trials, over 130,000 revealed that statin treatment prevented approximately 2 out of 10 major vascular events. Relative risk reduction of about 22%. Yes, it is a very important, considerable percentage of reduction of risk. But imagine here that statin prevent approximately 2 out of 10 events. So we still, the risk of 8 events is still present and this is what's called the residual risk, which is also very important. And I think a lot of research is going on, a lot of scientific studies are going on to uncover the residual risk and to find lines of management for this problem. Increasing the statin dose moderately decreases the cardiovascular risk. And if you have a look here in a meta-analysis of 5 clinical trials of about 40,000 population, high-dose statin therapy reduced the relative risk of major vascular events by only 15% versus lower dose statin therapy. Again, here a considerable percentage of reduction, but it is still a residual risk. And if you have a look here to this figure, which presenting to us the events per year, the percentage of events per year with low dose statin, which is 5.3%, which came to be 4.5% with high dose statin. So we still have a percentage of residual risk. Again, here from the TNT trial, even with the highest dose of statin, cardiovascular risk still persists. Major cardiovascular event percentage of about 11% with a 10 milligram of atorvastatin dose. By increasing the dose up to 80 milligram, imagine up to 80 milligram, the major cardiovascular event decreased to 8.7%. So we have only about 1.3% reduction, and we still have 8.7 residual risk. While statin reduced the cardiovascular risk, as we said, a substantial residual risk remains, and it is responsible for a lot of events. Elevated triglyceride is associated with increased risk of cardiovascular disease. And I'd like to stop here, which I think an important to stop. Why? Because now there is a trend and there is a lot of papers going on, a lot of research is going on for revisiting the triglycerides. Why? Because we are trying to find the hidden gates for the residual risk. And I think one of the hidden gates is the elevation of the triglyceride. This is what the evidence and a lot of evidence told us. What is the theory behind this? The elevated triglycerides play a role in the pathogenesis of atherosclerosis. Increasing the triglyceride lead to increase in the triglyceride enriched HDL particles, which leads to HDL particle dysfunction and reduction of the protective molecules of HDL cholesterol, which leads to increase in cholesterol in the arterial wall macrophage and leads to the progression of atherosclerosis. This is the one arm. The other arm, which is also very important, in which the triglyceride is responsible, is the increase in the number of small dense LDL particles. And as we all know, the smaller the particles, the more the heterogeneity of it. So the triglycerides are doing so. So increasing the small dense LDL particles leads to more oxidized small dense LDL, leads to inflammatory gene production, selectins, ICAM, VCAM, leads to increased cholesterol uptake by macrophage, increase the foam cell formation in the arterial wall, which leads also to the progression of atherosclerosis. So here we have a theoretical background for the progression of atherosclerosis, which is responsible by increase in the triglyceride. High triglycerides levels are markers for several types of atherogenic lipoproteins, which may be at significant risk of cardiovascular disease, even if LDL cholesterol level are at goal. And that's why we are talking about the residual risk. Why? Because even at the LDL levels are at goal, we still have a high cardiovascular disease risk, and one of which is the triglycerides is responsible. VLDL and VLDL remnants, as well as the chylomicron remnants, appear to promote atherogenesis independently of LDL. So here, the very low density lipoprotein and very low density lipoprotein remnants, as well as the chylomicron remnants, is also responsible for the atherogenesis, even if the LDL is within a goal or within the normal ranges. The presence of a small dense LDL appears to be mainly related to hypertriglyceridemia. As we mentioned from the algorithm before, that the higher the triglyceride, the more the small dense lipoprotein LDL molecules, which is responsible for more atherogenesis. Small dense LDL is associated here, as I mentioned, with a 3 to 7-fold increase in coronary heart disease risk, independent of LDL cholesterol concentration. We have here another important station for evidence, which is the PROVE-IT TIMI 22 trial. Even when LDL cholesterol is at goal, elevated triglycerides levels are associated with higher coronary heart disease risk, despite achieving LDL cholesterol goal with a statin. Patients with elevated triglycerides still have a significant higher cardiovascular disease risk, especially for those patients above 150 milligram per deciliter triglycerides. So achieving both LDL cholesterol and low triglycerides below than 150 may be important therapeutic strategy in patients, especially those after ACS, as studied in the PROVE-IT TIMI 22 trial. Again here, triglyceride and risk of coronary heart disease in the meta-analysis in Western population, over 250,000 participants, and another meta-analysis conducted in the Asia Pacific region of 26 studies of around 100,000 individuals. There is a 70% greater risk of coronary heart disease death and 80% higher risk of fatal or non-fatal coronary heart disease death in the highest triglyceride levels group compared to the lowest group. So we have an evidence here from the meta-analysis that the highest triglycerides increasing the cardiovascular death by 70% and 80% high risk of fatal and non-fatal coronary heart disease. And this risk recorded from the level of 75 versus 175 milligram per deciliter of triglycerides. Elevated triglycerides and low HDL both are associated with an increased risk of cardiovascular disease. And as I mentioned, those triglycerides and low HDL are gates for the residual risk, which we have to find molecules, which we have to find therapeutic strategies to act upon them to reduce this residual risk. Despite the risk associated with elevated triglycerides and low HDL cholesterol, these lipid abnormalities remain prevalent as most treatment target LDL. As we all know, and as we all know in the practice, we are trying to target the LDL, and this is right. This is our primary target, is to target the LDL to goal. But we still not spending a lot of effort for treating and targeting the triglycerides and HDL, which might be one of the residual risk theories. A limited number of patients achieve their lipid targets because of this. And I have a look to this slide that a significant number of patients have suboptimal triglyceride and HDL. This is from the National Health and Nutrition Examination Survey in the US. A proportion of US high-risk adults not at target levels for triglycerides and HDL, and those in different groups, those without any disease and those with cardiovascular disease, and we have a look here to those with cardiovascular disease, we can find that they achieve the target LDL cholesterol for 50% of treated patients, and only about 19% reach the target of all lipids. Also in diabetics, 14% reach the target for LDL cholesterol, but about only 17% for all lipids. And this is explained why there's still a cardiovascular events despite a tight control or reaching the goal for LDL cholesterol. Now we are reaching the very important station, which is the diabetic dyslipidemia, and what I'd like to say that the Bermuda Triangle, the elevated triglyceride, the increase in the small dense LDL, which is also the triglyceride is responsible for, and the reduction of the HDL, the protective HDL cholesterol. This is occurring in type 2 diabetes, presented by high level of triglycerides, low level of HDL. LDL by itself as a figure not significantly increased, but the problem here is the problem of the size of the LDL particles, which in which there is an increase for the small dense LDL particles, what's called the atherogenic dyslipidemia. This is the form of atherogenic dyslipidemia. This is actually a great challenge. And how can we reduce the significant residual risk of fatal and non-fatal macro and microvascular events in patients already receiving today's best care? Despite the best care of a statin and high-intensity statin therapy, still the residual risk there, especially in those patients with diabetes with atherogenic lipid profile. It is important to target here the atherogenic dyslipidemia, not only the LDL, to protect more the patient from cardiovascular events. And if you look here to the best evidence, which is the major guideline, which recognize the substantial cardiovascular risk associated with elevated triglycerides and low HDL cholesterol, we have a very important concept which we have to consider in our practice, which is the non-HDL cholesterol. And actually, the guidelines recently make the non-HDL cholesterol is a second target for managing dyslipidemia. Yes, we have a primary target of LDL cholesterol, but we have also to consider the non-HDL cholesterol as a secondary target. Why? Again, because of the concept of the residual risk, because when we are treating primarily for a target of LDL, we still have patients who develop cardiovascular events. That's why they plot the non-HDL cholesterol in the guideline as a secondary target. If we have a look here to the guidelines, European Society of Cardiology, European Atherosclerosis Society, American Association of Clinical Endocrinologists, and the National Institute for Health and Care Excellence, all mentioning the non-HDL cholesterol as a secondary target for therapy. So we have the strongest evidence for targeting the non-HDL cholesterol. And I'd like here to mention what is the non-HDL cholesterol. Non-HDL cholesterol is the total cholesterol, which is measured in the lipid profile, minus the HDL cholesterol, which is also measured in the lipid profile. And we have to mention here a very important statement that the non-HDL cholesterol incorporates all potentially atherogenic lipoprotein particles. And that's why also they plotted as a secondary target for managing. The National Institute of Health and Care Excellence 2014, the non-high density lipoprotein cholesterol is seen to be better cardiovascular disease risk indicator than low density lipoprotein cholesterol. It's more accurate, more practical, and cost effective. They here signify the importance of the non-HDL cholesterol. And again, in the guidelines of European Society of Cardiology and European Atherosclerosis Society 2016, they mention clearly as a class 1 recommendation level of evidence C that triglyceride adds information risk and indicates for risk estimation. And also recommendation 1, class of evidence C, non-HDL cholesterol is recommended to be calculated, especially in subjects with high triglycerides. In subjects with high triglycerides, as we mentioned, we have the possibility of increasing the small, dense LDL cholesterol, plus we have the possibility of figuring the number of the LDL cholesterol, and we are misleaded. So we have to have the non-HDL cholesterol, especially in those diabetic patients with high triglyceride, to be measured and to be also targeted as a secondary target. In 2017, non-HDL cholesterol should be calculated to assess risk stratification. So here another important statement, not only for targeting the treatment, but also for risk stratification to measure the non-HDL cholesterol in individual with moderately elevated triglycerides from 200 to 500, especially those diabetics and or established atherosclerotic cardiovascular disease. Another important sector which we have to consider for them, the non-HDL cholesterol, is those patients with insulin resistance. Especially those patients with insulin resistance, if they are suspected, should be evaluated to gain useful information regarding the individual's total atherogenic lipoprotein burden. So this is give us the importance of measuring the non-HDL cholesterol, and also here the consensus statement from the American Association for Clinical Endocrinologists here, as the first evidence came to light, is the secondary target with non-HDL cholesterol for those with extreme risk to be less than 80, for very high risk to be less than 100, for those with high risk is to be less than 130, moderate risk less than 160, and low risk less than 190. So here there is a clear evidence for targeting non-HDL cholesterol with a clear figures according to the risk of the patient. And the last station is the 2019 ESCC-ES guideline for the management of dyslipidemia, lipid modification to reduce cardiovascular risk. And here the triglyceride analysis is recommended as a part of the routine lipid analysis. This is a class 1 recommendation. We have to have a log, we have to have an evaluation, we have to have the risk assessment for the patient with the triglyceride management as a class 1 recommendation. Also, the non-HDL cholesterol evaluation is recommended for assessment, particularly in people with high triglycerides, diabetic patient, obese patients, or very low LDL cholesterol. So do not stop at the station of the low LDL cholesterol, especially in obese patient and diabetic and those patients with high triglycerides. We have to check the non-HDL cholesterol. We have to measure, we have to recognize as a class 1 recommendation level of evidence C. Again, the recommendation for drug treatment for patients with hypertriglyceridemia, there is a class 1 recommendation to use a statin for those patients with cardiovascular disease high risk if their triglycerides are more than 200. And high risk patient with triglycerides between 135 and 500, despite statin treatment, we have now a new drug which come to stage, which is the icosapent ethyl 2 gram by 2 in daily, which is a class 2 A level of evidence B. Back again to the triangle of Bermuda, which is the atherogenic dyslipidemia for diabetic patients, which actually they described it as a malignant nature, not always revealed by the lipid measures. Malignant, why? Because it is not always revealed by the lipid measures used in clinical practice, as LDL levels may remain within normal range. It may be better revealed by non-HDL cholesterol levels. This is a misleading measurement in the diabetic patients. So that's why we have to consider here the non-HDL is the way to go. Using only LDL cholesterol can misguide our therapy. If we have a look only to LDL, we will be misleaded for therapy. Why is it a successful formula to combine with fenofibrate in particular? This is a very important question when we are searching for a management for the residual risk. When we would like to combine another molecule with the statin to counteract the major problem of the residual risk, or for those patients with diabetic dyslipidemia, or for those patients with high triglycerides despite maximum high intensity statin therapy, we have to have another option. We have to have another weapon to use, which is the combination with a fenofibrate. Why? Why? Because there is a very important theoretical background behind this statement that fenofibrin activates what's called the PAPAR alpha molecules receptors. PAPAR alpha receptors effect on lipid and lipoprotein. It leads to lipolysis on triglyceride-rich particles, increases plasma clearance of triglycerides-rich particles, which is also important in the process of atherosclerosis. It also increases the oxidation of fatty acids. It increases the triglyceride synthesis. It decreases the level of dense LDL subtraction, increase the HDL cholesterol, and decrease the lipoprotein level. It has also an indirect effect on apolipoprotein. It increases ApoP1 levels. It increases ApoA2 levels. It decreases the dangerous ApoB levels. It also has an effect on cholesterol transporters, upregulate the tenses of cholesterol transporters. Another effects, which is a decrease in the plasma fibrinogen level, increase the C-reactive protein, which is also a marker of inflammation, and decrease in uric acid levels. So here, the very important mechanism behind the mechanism of action of the fenofibrate, which is the PAPAR alpha modulation. Lipid monotherapy expectations, clinical and lipid effects. The statins effect on LDL cholesterol. It decreases, of course, the LDL cholesterol much more than fibrates. The effect on HDL cholesterol, statin elevates HDL cholesterol, but the fibrates increase it more. The effect on triglyceride, as we see here, that the fibrates has much more effect on the reduction of triglycerides than statins. If you are talking about the safety, the efficacy, we have to also talk about the safety profile of fenofibrate. There is no or very little increased risk for myopathy when combining statin, because there is a fear always, there is inertia here to combine the statin with fibrates. But the evidence told us there is no fear for the risk of myopathy, especially in the with fenofibrate, as fenofibrate does not share the same pharmacokinetic pathway as gemcitabine. The risk of myopathy is much less with this combination therapy. Also, the risk of hepatopathy is less with fenofibrate when combined with statins. The long-term safety in real life, and this is what the FDA said, that in post-marketing reports, micronized fenofibrate, the particular form, which is the micronized fenofibrate statin therapy, showed a low rate of rhabdomyolysis, which is about 0.58 cases per 1 million person year. It's a very small number with rhabdomyolysis. This is what the FDA reported. And here is the recommendation for fenofibrates, that in primary prevention patients who are at LDL goal, triglycerides more than 200, fenofibrate may be considered in combination with a statin, which is a class 2B level of evidence B. Again here with the risk of pancreatitis, which is very grave problem. Omega-3 plus fenofibrate fibrate therapy, especially fenofibrate, should be initiated with N3 fatty acid 2 to 4 gram days and adjuvant therapy for counteracting the problem of pancreatitis for severely or very high triglycerides level. A very important issue here is the macro and the microvascular benefits of fenofibrate, and this is data came from the Accord Lipid and Field. And if we have a look here to the major cardiovascular events, we have we found that 31% reduction, and for total cardiovascular events 27% reduction, and for progression for diabetic retinopathy 40% reduction. Cumulative razor treatment for diabetic retinopathy, which is a microvascular problem, 37% reduction. Progression of microalbuminuria, 14% reduction. Diabetes-related amputation, 30% reduction. So here we have the benefits on macro and micro circulation, micro and microvascular circulation with fenofibrate, as we told from ACCORD and field trials. Again here, the fenofibrate micronized form plus statin combination, any type, has greater effect on triglyceride and HDL than statin monotherapy, which, as I mentioned before, has a great effect on the residual risk. And if we have a look here for fenofibrate plus atorvastatin, we can see that there's a 40% reduction versus 40% with atorvastatin only. And about 50% reduction versus 30% reduction also in the mean triglycerides for the fenofibrate plus atorvastatin group. And if we have a look here for the fenofibrate plus rosuvastatin, we can see that the main LDL cholesterol, we have 42% reduction, and we have main triglyceride reduction of 47% reduction versus 30% for rosuvastatin alone. So here we have an effective combination. We have a safe combination with the micronized fenofibrate with the statin to reduce both the triglycerides and LDL, and especially the triglycerides and non-HDL to reduce the residual risk. So as one of my final slides, the combination therapy may be necessary to address what's called the residual risk. The statin are effective at reducing death and MI in patients with coronary artery disease, mainly due to their effect on LDL cholesterol. Significant number of patients continue to have high residual risk, partly due to unmanaged atherogenic risky dyslipidemia. And that's why combination therapy for patients with high residual risk is very important and very crucial. Now we came to the last slide, which is the take-home message. Despite achieving LDL goals with intensive statin therapy, the residual vascular risk remains high in most patients. Patients at increased residual despite maximum statin therapy are especially those with elevated triglycerides, as we mentioned, and low HDL cholesterol. That's why we said that triglycerides are revisited. Elevated triglycerides and low HDL cholesterol levels are important therapeutic targets in patients at LDL cholesterol targets, regardless of the concurrent statin use. And new formulation of micronized fenofibrate 160 milligram proven successful for reducing macro and microvascular complication, as we shown. And finally, new formulation of fenofibrate 160 plus any statin, as we also show a successful formula for complete atherogenic risk management, and this was supported by the ESSC dyslipidemia guidelines 2019. And thank you for your attention.
Thank you, Professor Sayed. Actually, you extensively go through the optimization of the lipid-lowering therapy and the use of fenofibrates to adjust the cardiovascular risk in many clinical scenarios and clinical situations. So now we know from the guidelines now that triglyceride is very important. Triglyceride and other secondary goals of therapy now. And by the way, all the secondary goals of therapy are related to triglycerides. Non-HDL cholesterol, as you said, and ApoB, these are secondary goals of therapy. Why non-HDL cholesterol is important? Because if you look at the LDL cholesterol is not the only atherogenic part in our body. We have also very low density lipoprotein. We have intermediate density lipoproteins. These are called triglyceride-rich lipoproteins. They are increased when our triglyceride is high. So if you ignore this and concentrate only on LDL cholesterol, there will be, as you mentioned clearly, a residual risk, important residual risk. That's why the guidelines obligate us to look at these secondary goals after adjusting the LDL cholesterol. So it is not enough to adjust the LDL cholesterol of your patients to prevent cardiovascular events. You should have, all of us should look at, after adjusting the LDL cholesterol, look at the triglyceride. If it is above 150, should be treated. Look at the non-HDL cholesterol. look at the ApoB. These are, if not at goals, you should treat them. This is the first thing. I have only one question about the audience are interested mainly in fatty liver, and they ask about phenofibrates and fatty liver. And I think I know that there is many animal studies and many published papers about the use of phenofibrates in steatosis and in fatty liver. So it is very effective in this domain, especially if the patient have high triglycerides. And we know that the high triglyceride is the main pathological mechanism behind the fatty liver and the hepatic droplets in the liver. Any comment from Syed, from Salim?
Thank you, Dr. Syed, for this elegant presentation and very comprehensive review of management of dyslipidemia. I want to make a small comment and small question. About my comment, since long time, we hear about the pleiotropic effect of statins. Although it is elusive, but I think the pleiotropic effect of fibrates is much more evident. They have direct contribution to many metabolic pathways, like you have just mentioned, PAPAR alpha and others, away from its effect on the triglycerides and other lipid parameters. So also the pleiotropic effects of fibrates is very important. My question for you is, you know that we have LDL level for very high risk patients below 55, sometimes maybe less than 40, in high risk below 70, and so on. Why this is not mentioned clearly for triglycerides? We have HDL, non-HDL, but in triglycerides, why we don't have these figures and this correlation between the risk and the targets of triglycerides is a little bit not completely clear.
It's a very important observation, Professor Salim. And actually, the American Association of Clinical Endocrinologists they are now taking this step to mention that they are clearly put the targets, secondary targets, of course, after the primary targets of LDL for the non-HDL, as I mentioned. But the other guidelines, maybe the European guidelines, is mentioned, but not as extensively as what the American Endocrinologist Association mentioned, that extreme risk below 80, high risk, very high risk below, I think, 100, and high risk below 130, and intermediate risk 160, and low risk 190. So they are clear for non-HDL. And I think the reason here for what you mentioned is the number of study and trials which done over the targeting the LDL. But we still need a lot of studies for the reducing the triglycerides to what level, to decrease the level of risk to what level. I think we need such trials to make an accurate figures for the particular risks.
Yes.
So we know that triglyceride above 150 milligram per deciliter, despite statin therapy, deserve treatment because this patient is at risk. But as Dr. Salim said, we don't have goals. But we know that if it is above 150, we should treat despite, in addition to statin therapy. There is a question from the audience, Dr. Syed. What are the indications of combining phenofibrates and the statin? Is there any specific indications for this combination?
Yes, of course. We have a specific indication for that. And if we are not reaching the statin, or if we have intolerance with the statin therapy, for high intensity statin therapy, we have to combine with phenofibrates, especially the micronized form, to reach the secondary target of non-HDL and to reach the target of the triglyceride, especially in diabetic patient with atherogenic dyslipidemia. This is a very important sector of patients in which measuring only the LDL, depending only on the LDL, will be misguiding the management. So we have to combine on those patients. And also we have to combine for patients who are, for example, given 80 milligram of atorvastatin and cannot tolerate it, and they are not yet reached the target for triglycerides.
I think there is something in the net with Dr. Syed. So we can refer here.
We have to down titrate the statin, and we
So we can refer here, Dr. Syed, to the guidelines, as you said. The guidelines is putting fibrates in general as a class 2B indication in primary prevention if the triglyceride is above 200. So I don't have any more questions from participants. If there is no comments or questions, I think we can conclude these important sessions in the occasions of the World Hepatitis Day. We discussed a lot of issues relating to the lipid metabolism and the liver, lipid-lowering drugs and the livers, and finally optimizing therapy for dyslipidemia by adding phenofibrates when it is indicated to some patients in different clinical scenarios. Thank you, Professor Saeed. Thank you, Professor Salim. Thank you, Shawqi. And again, I would like to thank Abbott Company for their sponsorship of this waves, and thank ICOM for technical support, and see you later. Thank you. Bye.
Thank you.